Well done, Catherine. Some very clear messages there, and you're winding up, and you win the gold star of the day so far for finishing just before your time. So well done. Professor Mary Cannon now is going to join us. Professor Mary Cannon is working on the Advisory Support Group, a consultant psychiatrist based in the Royal College of Surgeons Ireland and Beaumont. Mary.
Thank you very much. It is an incredible honour for me to be part of the advisory support group for this assembly, and also I'm delighted to be able to speak to you today about a topic that's really close to my heart, the topic of prevention. Not just because I work as a psychiatrist, but because my research has been in the area of young people's mental health. And I firmly believe that we need to take a developmental approach to mental health and substance use. It has been shown that most adult mental health disorders, including substance use, people have already had a mental health problem, a severe mental health problem before the age of 18. So we need, if we're talking about prevention, early intervention, we're talking about a youth focus. Breda Smith touched on types of prevention. I'd like to go into a little more detail about this. She mentioned tertiary prevention. This is giving people the best possible help to improve their outcome and promote recovery. And we have heard a lot about this in the Assembly. We had Johanna Ivers talking about recovery capital. We've had site visits. These are people who are giving wraparound care, which is what you need for tertiary prevention. You need not just the good treatments, you need the employment benefits, you need the education help, you need social, financial supports, housing supports, okay? Now, the next type of prevention is secondary prevention, and this is what we know as early intervention, catching people before they fall off the cliff edge, if you like, of problematic substance use or mental health problems. And again, we've heard about this throughout the Assembly. The key thing about secondary prevention supports is they need to be accessible, there needs to be no wrong door, they need to be integrated so people don't fall through the gaps. We have heard about the work of the drug and alcohol treatment task forces, about general practitioners, adolescent services. This is all part of secondary prevention, really, really important. But primary prevention we're kind of, I suppose, dealing with today, and I'd like to talk to you about this. This is keeping people away from the cliff edge, stopping people using substances. And this requires a different kind of approach. This requires a public health approach, a public mental health approach. This is a whole society thing. We need to drive down levels of risk factors in the community, enhance protective factors. We need to focus on young people. We need coherent public health messaging. And I think this was mentioned this morning. We need very strong messaging coming from on top, a clear message. And we need education, but it's not just going into schools. This is education for the whole of community, the whole of society. It can't just stop when people leave schools. Two important things to remember about prevention. There's the prevention paradox, which is actually you can make more gains by focusing on reducing risk factors in the whole population and shifting the population curve to the left than you can by just focusing on people with the condition, the ones at the most harm. You can actually reduce levels overall better. The other issue, and I think someone mentioned this morning, the issue of unintended consequences. We must always remember the majority of the population do not use drugs. So any policies we make should not increase risk for the whole of society. We must take a whole of society approach here, as well as focusing on people who have the condition. How do we start thinking about prevention? I think we should look to international comparisons, to countries that have low rates. Now, this graph here shows rates of cannabis use disorder worldwide. The red countries have very high rates in young people. The more blue the country, the lower the rates. So we should be not looking to countries with the red countries, we should be looking to the blue countries. This is the SPAD survey, which was mentioned earlier this morning. The lowest, these are rates of cannabis use in young people over many years. And you can see the lowest rates there are, that is Iceland. So let's have a look at Iceland and see what's going on there. They had the highest rates of substance use 2 decades ago. Their young people were binge drinking at epidemic proportions. The government decided they needed to do something, and also local communities. So they implemented the Icelandic prevention model, the Planet Youth model, which has driven down substance use. They're now the lowest in Europe. I think it was mentioned this morning, the key elements are data collection, and devising interventions, more data collection to see if they're working, devising interventions again, tweaking the interventions. This is a constant iterative process. In Ireland, this has already come into Ireland through the efforts of the Drug and Alcohol Task Forces and the Education Training Boards. It's been running in Galway and Mayo Roscommon for a number of years. It's now started in North Dublin, Cavan and Monaghan. And I've been involved with that. We get some interesting information on risk and protective factors. I'm talking about cannabis use in young people. 7% have used cannabis in the last, these are transition year students, in the last month. This is about the European average. The risk factors are other substance use and also peer pressure and peer use. Protective factors, the strongest ones were parental supervision, parental attitudes to drugs, and also another protective factor was a young person believing that drugs are harmful. So we can see the potential for intervening here in terms of social messaging and education. We have some interesting preliminary results on young people who have not touched any substances by the age of 16. What factors are associated with this group? Interesting ones are access to public transport, participation in sports, again, parental factors, and also parents who can afford basic necessities. And this leads me on to some of the work that Catherine was talking about on this very important area of adverse childhood experiences, or ACEs as we call them. These, Catherine went through some of these. We have 5 to do with the young person themselves and 5 to do with their parental familial environment. I just want to point out again that parental problematic substance use is actually an ACE, and we need to bear that in mind when we're talking about hidden harms. In terms of outcomes of ACEs, the key thing about them is if someone suffers multiple ACEs, so more than three ACEs during their childhood, they are at higher risk of problematic, both physical and mental health use, but the highest effect is for problematic drug use. You can see the bottom line there in adulthood, 10-fold increased risk if you've had 3 or more ACEs. And we had a lot of talk about this in the lived experience panels and the effect of childhood trauma. So we need to prevent ACEs. And how can we do this? I want to talk to you about the work of a very inspiring figure called Professor Sir Michael Marmot in the UK. He has taken a health equity and social justice approach to this. He said there's clear evidence that policies can make a difference. This can come from top down. If a government, if the local leadership believes in this, then things can happen. He has had influential reports, Fair Society, Healthy Lives, and then the Marmot Review 10 years on. He has devised a set of Marmot principles. The key one here, the first one is give every child the best start in life. And what's happened, he's been trying to influence, you should look at him on YouTube or his talks, very inspiring. The UK government haven't quite taken it on board, but interestingly, some cities have said, we want to be a Marmot city, Coventry and Ghent. We want all our policies to embed these principles within them so that every child can get the best start in life, so that create fair employment and a good work for all, racism, discrimination. You can have a read through those, they're very inspiring. So we've all heard, as Paul mentioned this morning, we've been riveted to this, the MV Matthew, this ship coming towards Ireland with hundreds and millions of euros worth of cocaine on it. As we heard from the legalisation session, we cannot stop the supply. There's an endless amount out there. What we can do is try and stop the demand, take the handle off the pump. And this is a key tenet of epidemiology. John Snow, back in 1850, there was a cholera epidemic raging in a part of East London in Soho. People were dying. No one knew how cholera was distributed. Everyone thought it came through the air.
Just 2 minutes, Mary. Just 2 minutes. Take it on.
Okay. He noticed that they'd all used water from the same pump, the Broad Street pump. And even though there was no scientific evidence at that time, he got the handle taken off the pump, and the rates of cholera went down. We need to do that kind of approach. We need to take the handle off the pump and stop driving the demand for drug use. So that, I suppose, trying to give you a flavour of the idea of prevention capacity, which is that we can change the whole society, community, to allow the best outcomes for everyone, for our young people and for older people, for families. And this is not done by focusing just on the individual. This is done by focusing on the individual within their family, within their school, within the broader society, within our government. And this is, I'm not going to deny, this is a complex problem. We've heard it described as a wicked problem. Complex problems require complex solutions. And, it's a mammoth task ahead of you. And I have so much respect for the work you've all been doing since this assembly started. And I have no doubt that you will tackle this and come to the best possible outcomes and solutions. And I wish you the very best of luck with your deliberations. Thank you.
Thank you.